Okay. Okay. Okay, guys. So thank you for attending, and again, thanks for attending. And I apologize for the short notice. Okay. Okay. So we will present. We will start, guys. So I'll try to be interactive, please. I will show a couple of ECGs that I was asked to prepare for that upcoming conference. I apologize in advance if I'm being quick, and please interrupt me for any questions. Okay, guys? Okay, so case one. So this is a 26 years old. I recently encountered roughly probably 6 months ago, maybe. Or maybe a year ago, sorry. So 26 years old, she was a 2 month postpartum. She had history of recurrent syncope and alarm. Specific trigger was alarm, like alarms, morning alarms. And there is family history of sudden cardiac death. Her mom and a couple of cousins. Okay. Okay. So that's her ECG. I met her at Amiri Hospital. So guys, what do you think might be the reason for her family history and recurrent syncope based on this ECG?
I think long QT type 2.
Okay. Abbas, excellent. So there is definitely long QT interval. Okay, guys. And then we'll talk about types maybe later, but definitely everyone recognizes the QT is very long, right, guys? This should be very obvious, right? Plus, not just very long, it just looks very odd, very funny. For example,
Yes.
inversion lead one, just very odd looking T waves. Okay. Okay. So she subsequently after the admission, she started doing this, which is like polymorphic ventricular non-sustained tachycardia. And this is probably why she was having syncope at home. And when she presented to Amiri Hospital, she was having also decreased function, probably secondary to frequent polymorphic ventricular tachycardia. Okay. But luckily she'd never arrested yani. Okay. So just really quick, whenever you encounter a patient with long QT interval, you always should ask yourself, is it a congenital reason or an acquired reason? Okay. With acquired reason, obviously you want to rule out metabolic disorders like electrolyte disturbances. Some patients, when they are bradycardic, the QT might prolong, or if the patient is on a specific medications that prolong your QT interval, and there are many drugs that might prolong your QT interval, and there are other factors such as like intracranial disease, hypothermia, and so forth. Okay, so there's a very long list of acquired causes of QT prolongation that you want to rule out before calling someone having long QT syndrome, okay, or congenital form of long QT. Okay, in this case, there is no, there was no specific acquired, cause of long QT interval that was identified, and there's also positive family history. So you obviously should think more of congenital long QT syndrome. Okay. Okay. So for the congenital long QT syndrome, in order to definitely diagnose long QT syndrome, there are specific criteria. So one criteria is if you use something called Schwartz score, and if the patient scores more than or equal to 3.5 in that Schwartz score, then the patient indeed meets criteria for long QT syndrome, and I'll show you the Schwartz scores in a second. Or if the patient had a pathogenic mutation known to cause one of the long QT syndromes, or if the patient had a QT interval above 500 using Bezet's formula without secondary reason or secondary cause of QT prolongation, okay? Or if the patient had 480 to 499 milliseconds of QT interval with unexplained syncope, then long QT syndrome diagnosis is established, okay? So that's the Schwartz score that you might use whenever you suspect long QT syndrome. I will not go into details. I just want you to be aware that there is Schwartz score that you might look up for any patient that you encounter with possible long QT syndrome. Okay, it's self-explanatory, and it's a probability score. So meaning if you score more than or equal to 3.5 point, then you have a high probability of established long QT syndrome. Some people also do epinephrine challenge test, especially for suspected type 1 long QT syndrome, to elicit QT abnormal QT prolongation. And these ECGs are examples of T-wave alternance. If you don't know what's T-wave alternance, which just means there's T-wave changes in each and every beat, okay? Which is usually a sign of impending arrhythmia and torsades, okay? So for long QT syndrome, the prevalence is around 1 in 2,000. This is in the Western, countries. We don't know exactly what's the incidence in our or the prevalence in our countries, but it probably is a little bit more than 1 in 2,000, I would imagine. Anyways, it's not very, very, very rare. Like it's roughly equivalent to SLE, okay? It's a syndrome with that it might be very challenging to diagnose, especially because many of the patients with long QT syndrome have incomplete penetrance, meaning their ECG that you do at a single point in time might show normal QT value, just because that patient, the QT is dynamic, and during the clinic visit, for example, his QT might be just fine, but when he goes home and runs and plays and stuff, the QT might have normally prolonged. So you might not detect the QT prolongation in each and every ECG that you might order for the patient. So this is why sometimes it's very, very challenging to establish the diagnosis of QT syndrome. And that's why when you have a family with an established gene mutation that causes long QT syndrome, you should screen the rest of the family members with the genetic testing rather than ECG, because again, the ECG may or may not show the disease. Understood, guys? I'm sorry if I'm too quick, but let me know if this doesn't make sense. Does it make sense so far, everything?
Yes, it's
Yeah.
okay.
Okay. Okay. So the values for the QT intervals that you need to remember is that, more than or equal to 480 in adult females, more than or equal to 470 in adult males. Okay. The borderline are between 460 and 480 for females, 450, 470 for males. Okay. And also you need to know that there are so many types of long QT syndrome, roughly 17 types of long QT syndrome, but there are 3 major ones, which is type 1, type 2, and type 3. Okay, so there are major genes and minor long QT syndromes. So major or frequent long QT syndromes and minor long QT syndromes. Okay, and when you suspect long QT syndrome in a patient, it's a standard of care to order genetic testing, and the genetic testing yield is very high, roughly 80%. So roughly 80% of families with definite long QT syndrome will have an identifiable gene mutation, okay? And then when you screen the rest of the family members, you want to do ECGs, of course, but you also want to do that specific gene testing that runs in the family for each and every family member at risk. Okay, guys? So again, when you have an established gene mutation, this is how you should screen the rest of the family members, not just ECG. You have to do the genetic testing. Okay, guys? Questions, guys? Obviously, long QT1 is the most common, okay? And then 2, then 3, okay? Okay, guys. Um, so this is case 2, okay? 22 years old with recurrent syncope. There is family history of sudden cardiac death. She has 2 sisters that died suddenly. She is deaf. The patient is deaf. She's a product of consanguineous marriage, and she was treated for seizure disorder for the past roughly 20 years. And that's her ECG when we first met her. Do you guys, can you guys explain her symptoms based on this ECG? Is there something that worries you about that ECG? Guys. Mervet, I see you here. Anything that worries
هي
you?
هي براديكارديك
Okay,
وال
bradycardic. Yeah, I
الكيو
agree with
تي
you.
برضه prolonged
Yeah,
وبعدين التي ويف in some peaked in some leads
okay,
V2.
excellent. Okay, so she's bradycardic. Her QT, you want to measure it, of course, but it might look, generous. Okay, it does look generous, and you said peak T waves and so forth. So this has, there is a suspicion of long QT syndrome, and that might explain her syncope, her family history of sudden death, and so forth. Okay, and I did the measurements for you guys, and these are her. Obviously, the RR interval is variable. So the QT interval would vary a little bit. So these are the numbers that I'm getting: 500, 456, 530, 480, 456, and so forth. Okay. So there is definitely QT prolongation. Someone wrote in the chat Brugada. There's no Brugada. I'll show you any Brugada ECG later, but this is not Brugada ECG. You have to look at V1, not AVR. Maybe you looked at AVR. Anyways, so QT is generous, okay? And then this is a segue to the next slide. So again, back to long QT syndrome, there are autosomal dominant forms and autosomal recessive forms. The autosomal recessive forms are usually long QT type 1, or they are long QT type 1. And if there is hearing deficit, this is called Jervell-Lange-Nielsen syndrome. Okay, so this patient had Jervell-Lange-Nielsen syndrome, gene proven, and obviously, history was very suggestive. Okay, so again, with long QT, back to long QT syndrome, there are autosomal dominant forms and autosomal recessive forms. So you have to be aware of the autosomal recessive forms. Again, consanguineous marriage, hearing deficits, QT prolongation, you have to suspect Jervell-Lange-Nielsen syndrome. Okay, and then she was treated for seizure disorder for like the past 20 years incorrectly. Okay, her seizures were cardiac in origin. Okay, so unfortunately she was misdiagnosed for 20 years, and she was in Syria, she was in Jordan, she was in Kuwait, and so forth, and no one recognized that she has Jervell-Lange-Nielsen syndrome until just 6-8 months ago. Okay, so that's very unfortunate. So you guys have to be aware of that syndrome. Okay, you guys heard of this syndrome before? Anyone?
اه
Yeah.
تمام.
Common
معلش
MRCP question.
So that
دكتور
patient,
محمد معاك سؤال معلش لحضرتك دلوقتي لو هو عيان اوريدي كان متشخص ان هو ابيليبسي وكان اوريدي على انتي كونفولزنت مش برضو الانتي كونفولزنت ممكن تعمل لونج كيتوي سيندروم ولو هي بتعمل كده هل ساعتها اقدر افرق ما بينهم ازاي؟
yeah, good question. So obviously the QT is long here. You are wondering whether it's related to the anti-epileptic drug, صح? So you have to look that drug, and then if it indeed prolongs your QT, then طبعا we did genetic testing, and then the genetic testing proved that she has long QT type 1 mutation that was homozygous. بمعنى الأب عنده mutation, الأم عندها mutation, and the kid inherited both mom and dad mutation. So that fits, that is, that suggests Jervell-Lange system. So she has gene mutation proven, which
تمام
explains her syndrome. Okay, so then we stopped her anti-epileptic medications, and she's not having seizures even after anti-epileptic medication being stopped. Okay, so we proved it genetically. Okay, but it's a good question, Nabi. Okay.
تمام
Okay, so there are long QT types that has other manifestations, non-cardiac. For example, long QT type 7, long QT type 8. These are rare forms of long QT. And by the way, we do have type 7, type 8 in Kuwait. So you just need to be aware that sometimes long QT syndrome is associated with extra cardiac manifestations. Okay, I will not go into details. You have to be aware of this. Okay. Okay, so this is a more important slide. So this is a study that included around 509 established long QT syndrome patients, and this is a graph of normal QT value for male and normal QT value for females. Okay, and as you can see, like in 3,000 controls. Okay, and if you can see, so this is the second graph, is the long QT values or sorry, the QT values for long QT syndrome patients in that study, okay? So as you can see, the QT is very dynamic. Some patients had a QT interval of 360, but they had definite long QT syndrome, you know? And some patients obviously had QT interval of 760, okay? But the average long QT, the average QT interval in the long QT patients were around 482 milliseconds, okay? So as you can see, there is an overlap. So there are patients who are normal with, there are patients with long QT syndrome, but have normal QT interval values, okay? So this is why it is a challenging syndrome, okay? So there's an overlap zone, okay? So again, we usually use 470 and above in adults for males, 480 and more for adults and females, and in pediatrics, 460 for both. Okay, so in other words, there are many long QT syndrome patients that are concealed or hidden, and roughly in this cohort, is around 40% of them had ECG value or QT intervals of less than or within normal range. Okay. So it's very common that long QT syndrome patients do actually have normal QT intervals, at least during the ECG that is taken. Okay, guys? So it might be very tricky. Okay. So in other words, just measuring the QT is not enough. So again, if you have this family who son, for example, has definite long QT syndrome, and you tell dad, I want to see your ECG, and the dad ECG is normal, it doesn't mean that dad doesn't have long QT syndrome. He might be one of those concealed, right? So that's why if you have gene positive mutation, you screen dad or mom for that gene, not just only ordering the ECG. Make sense, guys? I'm repeating this very, very frequently because this is a common mistake. Okay, guys? Understood?
تمام يا دكتور محمد. معلش يا دكتور محمد، سؤال تاني.
Yes.
هل الهولتر هيقدر يفيدنا في اللي احنا نشخص اللونج كي تي سيندروم ولا لا؟
Yeah, good question. So Holter, I don't usually measure QTs in the Holter because there is 24 hours worth of tracing in the Holter, and who is able to measure QTC in the machine would do it electronically, okay, which is usually very wrong. Okay, so you have to do it manually, and then do you think someone is able to measure the QT interval value in a 24-hour patient? It's very difficult. Okay, and we in general don't know. Like the QT, again, even normal individual varies during the day. Okay, we don't even understand the variation that normally happen in normal patients. Okay, so the Holter QTC interpretation is very tricky. So I don't usually look at it. I don't usually worry about it unless like it's super duper obviously very long. But if it's borderline, I usually don't consider it. Okay, so I measure the QT during the clinics or post during stress test or post exercise stress test. Okay, so these are my usual measurements for the QT interval, in clinic, resting ECG, or post-exercise ECGs during stress test. Okay, not during the Holter. Okay, Nabil?
اوكي يا دكتور محمد. اوكي يا دكتور.
طبعا if I have a patient I know that he has long QT syndrome, when I do the Holter, obviously if the QT, if the patient's having T-wave alternance or very, very, very prolonged QT, that helps me knowing that this patient is high risk. Okay, but for someone who has no diagnosis, I don't diagnose him as a long QT patient based on the Holter. Okay.
تمام يا دكتور محمد. شكرا لحضرتك.
Okay. So how do you measure the QT? Obviously, unfortunately, people measure it wrong all the time. Okay. So usually what you should do is you draw a line in the isoelectric segment of the ECG. So from the PR interval all the way to the TP interval. Okay. So you draw a line. Okay, so this is your baseline line. And then you draw another line on the inner side of the steepest slope of the T wave. Okay, so this line this line is aligned to the steepest slope of the T wave, and then where those two lines intersect, this is your end of the QT interval, and then the beginning of your QT interval is the onset of your QRS. Okay, so this is your QT value. Okay. And then obviously you want to avoid, if you see U wave, small U wave, you want to avoid U wave. You don't include the U wave in your measurement. And obviously then you divide it by square root of the RR interval of the preceding RR interval. So this RR interval, not the RR interval, of this beat, but the preceding RR interval, okay? Okay, so preceding RR interval, and that's how you measure this is how you figure out the end of the QT value interval, okay? Make sense, guys? So this is called the teach the tangent method, okay? Which no one does, I know, but this is what you should do, especially when you are inexperienced, okay? If you are a very experienced QT, long QT expert, then you don't have to do that. You should still do it, but you may trust other, you may do it differently. But if you are unexperienced, this is how you should measure the QT interval, okay? Again, you avoid the U wave unless the U wave is so big, which like more than 50% of the amplitude of the T wave, then you can include the U wave. For example, if you have a T wave that looks like this, you want to include that U wave because this is too big, okay? طبعا V2, I usually don't look at V2 because V2 almost always has a big U waves, okay? So ideally, you use lead 2 and V5. This is what usually people do. They use mainly lead 2 and V5 to measure the QT interval. Obviously, you can look at each and every lead, but the standard of the measurements that are more standard, usually use this lead 2 and V5. Okay, this is where the QT is best defined, or the T wave is best defined. Okay. So again, don't usually use V2 and V3 because V2, V3 usually have big U waves and it confuses you. Okay. And then we did one.
محمد معلش انا اقطع حضرتك. هو انا مسموح ان انا اقطع في النص ولا اسال في
لا
الاخر؟
please قاطعني because that's good.
طيب
Means that
معلش يا
people are
دكتور،
paying
ممكن
attention.
بس الاي سي جي اللي حضرتك لسه عارضه، اللي هو الكيس بتاعه النيلسون سندروم، بعد اذن حضرتك
Yeah.
بس توقف لنا تاني دقيقه واحده.
Yeah. This one.
هي دي قصد حضرتك في الميجرمنت بتاع اليو ويف ده، اللي هو اللي تحت. احنا دلوقتي عندنا برولونج كيو تي، والويف الكبيره اللي بعد دي هي اليو ويف عندنا في اللونج ستريب. معنى كده حضرتك بتقول احنا
لا
هنقيس من الكيو
you mean
لغايه
this
اخر
one?
اليو دي. انا قصدي على دي.
This is artifact. This is not U wave. This is just movement
اه
artifact. So this patient
ما
doesn't.
عشان كده انا شفتها وما كنتش عارف دي ايه الصراحه.
That's just movement artifact. Okay. So for example, for this patient, you draw a line here, then بعدين you draw a line here where it intersects. You stop. This is your end of the QT, and then this is your RR interval. Okay. طبعا try to use, when the ECG is very messy, it's difficult to do those lines. But for example, here this is a nice steady ECG. You just draw a line from this TP to this TP, for example. Sorry, from this PR to this PR, you draw a line, and then you draw a line at this steepest slope of the T wave, and then it intersects, let's say, somewhere here. So that's your QT, and then this is your R interval for that QT. Okay, so that's why here you see the R interval here is so long. So this QT is divided by this prolonged long R interval. That's why the number is less. You understand? Okay.
تمام.
Okay. Anyway. Okay. Good question, Nabil. You are very interested today. Excellent. Okay. So we did this study. This is now a couple of years ago, and we showed that ECG to pediatricians, and only 60% recognized the QT is very long, but 40% did not among pediatricians and cardiologists. So again, QT recognition is not the greatest. Okay, so that's why I'm stressing that you guys need to look at the QT interval, measure it correctly, and don't miss a long QT syndrome patient, okay? Because obviously they are at risk of sudden death. Okay, so again, just to reiterate myself. So usually try to use lead 2 and V5. Avoid V2, V3. Okay, and then one trick that you may use is that you measure the QT, you just measure the QT, not the QTC, the QT, okay? And then look at the QTC, like for example, this is ECG of a patient. So the machine is telling you the QT value is 352. and the QTC is 374. So you measure the QT yourself. And then if it was indeed 352, then you know the QTC that the machine recorded is right. If your QT is different than that QT, then you have to remeasure everything. Okay, so that's one way of doing it quickly. Just confirm that the machine QT interval is you agree with, some is an interval that you agree with. Okay, and or another trick that you may use, if the QT ends before half the RR interval, then the QTC would measure usually normal. Okay, but you have to be careful. The patient should not be bradycardic. So if the patient bradycardic, this rule is inaccurate. So if the patient is not bradycardic, meaning heart rate above 60 and between 60 and 100, and the QT ends before half the RR interval, then this usually is a very reassuring sign that the QTC would be normal. Okay, it has a high sensitivity. It's a high it's a high sensitivity measurement. Okay, but if it's longer than the half RR interval, you have to measure it yourself, and it may or may not actually measure as long. Okay, understood these two tricks, or you did not understand?
تمام يا دكتور محمد.
متولي، نبيل، عباس، سمية.
عمر يا دكتور محمد.
Yeah.
تمام تمام إن شاء الله.
Tamam? Okay. So again, just make sure the patient is not bradycardic, which is luckily not usually the case in pediatrics. Okay. If you have sinus arrhythmia or AFib or something, the patient heart rate is not steady, you want to then take the average, like what I did for the Jervell-Lange-Nielsen syndrome. You just take the average, okay? Because the patient heart rate was varying, okay? And then when you have a patient who is extremely bradycardic, usually the QT would be underestimated. And if the patient has a tachycardia, usually the QTC would be overly estimated using the Bézès formula. So you have to be careful. Try always to measure the QT when the heart rate is appropriate. Okay, so for example, don't measure the QT interval in someone who's tachycardic, septic, or whatever. The heart rate would be fast, and then you will overestimate the QT value. Okay, so don't measure your QTC when the patient is not doing well, meaning tachycardia, or if the patient for whatever reason is extremely bradycardic. You wait for the heart rate to normalize if possible. Okay. And then if you have wide QRS, let's say a patient with congenital heart disease has right bundle branch block, post-op, whatever, usually it's the QTC would be prolonged. Why? Because the QRS is part of the QT interval. Okay. So again, you're measuring the QT. The QRS is wide, then the QT would prolong. Okay, by default. Okay. So if you have wide QRS and you measure the QT, often you will have a borderline prolonged QTC. So then you don't know whether this is relevant or irrelevant. Some people correct for that, so that it just normalizes the QRS interval. But just so you know, it's very rarely that a patient who has wide QRS will indeed have long QT syndrome. It's rarely associated, meaning, when someone has congenital heart disease, it's very often, it's very rarely that the patient has a congenital heart disease plus long QT syndrome. They are not really usually associated, except very rarely. Okay, so that's which is nice, because then it makes things easier. But again, if you have someone with right bundle branch block, but the QT is super long, you have to suspect it still. But if the QTC is borderline, some people will adjust for the QRS widening and then go from there. Okay, but just the QRS widening would artificially prolong your QTC value, and then it's difficult to be sure that the patient has or has not long QT syndrome. Okay. So Abbas said that the first patient has long QT type 2. He probably said that because he knows that the long QT 1 and 2 and 3 each has a specific T-wave morphology that suggests that is typical for that type. Okay. For example, long QT 1 has usually such a T-wave. Long QT type 2 usually has a bifid T-wave. Long QT type 3 has a very prolonged isoelectric segment and then T-wave. Okay. So each long QT type has specific T-wave morphology. And if you remember our first case, this is the T wave of the first case. So what do you guys think? Do you agree with Abbas? Is long QT type 2? Or not, guys?
3 type 3.
So I heard 3. So again, 3 has a long isoelectric segment and then the T wave. Okay. Do you see a long isoelectric segment, or you see a T wave that starts right away? There's no really isoelectric segment. صح?
أنا أعتقد إنها تايب
type
2.
2.
Yeah, type 2. So there's bifid T wave. Okay. So yes, Abbas, طبعا the patient also postpartum usually suggests type 2. Alarms usually suggest type 2. So there's a couple of hints of type 2 for that patient, but also the T wave suggests type 2 as well. So this patient is classical textbook type 2 patient, in which they have arrhythmias usually postpartum, and they have arrhythmias when they are with noise alarms. Okay. And the T wave looks as such. Okay. So for the second type, this is the T wave, so there is, I know this might look like long isoelectric, but, there is just, it's not really isoelectric. It's like the T wave is late peaking. Okay. So that's more of long QT type 1. Obviously, looking at the T wave is just a sign. You can guess what type it is, but obviously it's not that sensitive. Okay. Okay. So the first case was type 2. The second case was Gervais-Nielsen type 1, of course, KCNQ1, which is type 1 autosomal recessive long QT syndrome. Okay. Okay. So long QT type 1 usually exercise triggers events. Long QT type 2 usually auditory startle triggers event. And long QT type 3 usually events happens during rest. Okay, usually. So when you take history, any syncope that is exertional, mid-exertional, meaning patient is running and suddenly collapse. Not patient is running and then he gets tired, he rests and then faints. This is more vasovagal. But mid-exertion, this is very concerning. Auditory syncope is concerning. Postpartum syncope is concerning. Okay, so you have to take good history. Okay, so again, for long QT type 2, pregnancy and postpartum period especially is a high risk in terms of malignancy, in terms of long QT events. Okay, okay. So obviously, management, patient needs to be well hydrated. You want to avoid QT prolonging drugs. There's lists using such website. Okay, you want to teach family CPR. You want to avoid triggers, and then obviously you want to start beta blockers. Okay, so you give beta blockers to everyone with established diagnosis, except very, very rarely, and this should be an expert, expert decision. Okay, so most patients will require beta blockers, except except some patients who are considered low risk, and then people might just monitor them. Okay, but this is not a decision that you should take easily. You have to be an expert to make that decision. Okay. So what beta blockers you want to use is non-selective beta blockers. So again, such as nadolol and propranolol. Okay, so nadolol and propranolol, not any other beta blocker. Okay, they have been shown to be the best protective beta blockers for long QT syndrome. Okay, and if you have type 3, flecainide, mexiletine might also be beneficial. Okay, but type 3 is rare. We don't have I don't think I have any patient in Kuwait with long QT type 3. Okay, the another form of therapy that you might want to consider is sympathectomy, especially if the patient is unable to tolerate beta blockers, or you're worried that the patient might be high risk despite being on beta blockers, or if the patient needs something else than beta blockers but refuses ICD, then sympathectomy is a good option. Okay. ICD is only indicated if the patient survives a cardiac arrest, or if the patient had symptoms, syncope or arrest while on therapy. Okay, so ICD is not prophylactically given, is only given when the patient is having symptoms despite being appropriately treated. Okay. So questions, guys, for long QT? Okay. And then just,
طب دكتور محمد sorry if the patient is concealed يعني diagnosed by
yeah,
genetics
yeah,
only symptoms in one of his kids we
yeah.
will treat him also if concealed.
Yeah, good question. So if he's pediatrics, usually, me, I usually treat, I'm not usually comfortable not treating, okay? Again, there are experts that are more experts than me. They might elect not to treat, but me, I almost always treat pediatrics. Now, adults, let's say the dad is already 50 years of age, above 40 years of age, then they are low risk. And I offer them therapy, but I tell them, you are low risk. You never had any symptoms for the past 40 plus years. I am less worried about you. And then I give them the option. But young adults, pediatrics, I treat regardless, even if the QTc is normal, okay? But again, there are specific type of patients that they may not need therapy, but it's difficult to know for sure which patient is among that group. Okay, there are specific criteria that people may use, but in general, for me, I'm mostly pro beta blockers. Okay.
Okay.
Okay. So Merve, sorry. So this is case one again. So this is the patient now, back to case one. The patient is now pregnant, by the way, and I'm worried about her, of course, when she delivers. But now this is her QT while she's pregnant on Nadolol. Okay. Look how nice is her QT, number, the QT value, he's around 430. It really doesn't look, I mean, if I showed you that ECG, you will never say she's a patient with long QT syndrome, right? It really looks very normal, right? So this is why it's challenging, Imagine this patient, let's say her sister had long QT syndrome, and you do the ECG for her, you will never realize that the patient has long QT syndrome, right? This is why, again, genetic testing is very important. And this is how the QT might fluctuate so much. And then, with therapy, it might also be more stable and maybe slightly, more towards normal value. Okay, guys? But this is her ECG just recently. Okay, she's now, I think, she will deliver in April. So I don't know how many months pregnant she is, like 3, 4, 5 months pregnant already. And so far she's doing well. Like since therapy, since Nadolol, no further syncope, function normalized, and no VT that we had seen. Okay, on Nadolol. Okay. Okay.
معلش
Question.
يا دكتور محمد، هو احنا بندي الدوز لغاية اما الكيو تي ترجع نورمال ولا
No, no,
على
no.
اساس السيمتومز؟
No, we just give the appropriate dose for the patient, and we try to give a good dose that is, therapy. Like, there are specific, like, for example, for Nadolol, 1 to 1.5 milligrams per kilo per day, once a day. And then, if the patient has no side effects, then, this is the dose. Okay. Even if the QT remained high, unless the QT is like all the time above 500, then I might worry. But if the QT below 500, but still high, I usually just monitor. I don't do anything else. Okay. If the QT, for whatever reason, is always high, always above 500, then I might worry that this patient is at higher risk for events, and I might do something else besides the beta blockers. But this patient only on beta blockers, despite having VT before and syncope before, and she's now on beta blockers for the past roughly, I don't know, maybe 1 year, a little bit less than 1 year, and so far so good. Okay.
تمام طبعا.
Okay. Okay. So again, most patients will only require monotherapy beta blockers. You want to measure the QT correctly, take good history, avoid the U waves. And if the QT value is above 500, this should be respected. And don't forget to screen the family members, first degree family members. Okay. Okay. Case 3. So this is 40 years old. I know you guys are pediatrics, but this is relevant to pediatrics as well. 40 years old with palpitations. Okay, this is the father of my patient. Okay, this is why it's when you guys attend my clinic, I always examine Abbas nose. I always ask ECG for parents. So you have to know adult ECG a little bit. Okay, so that's the father of one of my patients. What do you guys see?
WBW.
WW.
I don't know. There is a short PR interval.
Do you see like clear P waves that يعني all the time?
No. That's why it's here. In V3, there is a short PR interval.
V3?
I'm not sure.
Yeah, I don't know. I mean, do you see delta? I mean, if you think this is P, okay, why is it irregular? For example, why is there like why is it irregular, you think? Why is the P wave super duper small? I mean, what comes in mind if something is fast and irregular? Adult.
Okay.
AF, hello.
Yeah.
So this should be this you can imagine so much P waves, okay? So either atrial of some sort or AF. When he's 40 years old, so AF is very likely. Okay. And what about V1? What it looks funny, V1, right? Look at V2. The RS, R, and then this, the end of the QRS looks funny, right? Does it look, yeah, I mean, it has to look funny to your eyes. At least you should worry about, for example, right bundle branch block, something. It looks funny, right? V2 looks very odd. Okay. So what is this funny, what is this funniness might suggest?
PV Brugada.
Yes, Brugada. Okay. So this is a patient who had this ECG and presentation, and then you see AFib and you see possible Brugada on V1. An AFib is common in Brugada syndrome, by the way. And, this is, you have to suspect Brugada syndrome, okay? So what is Brugada syndrome? This is how you diagnose Brugada syndrome. When you see SC segment elevation, okay, in type 1 segment, and I'll show you what do I mean by type 1. So there's type 1 segment elevation morphology of more than 2 millimeter, more than or equal to 2 millimeter, and more than or equal to 1 lead in the right precordial lead. Okay, so you want to see more than 2 millimeter segment elevation and more than 1 lead on the right. So for example, V1, V2. Okay, either spontaneously, meaning like this patient presented like this, or after a challenge drug test or provocative drug test. Okay, so there are drugs that you give to patients you suspect Brugada, and then you will get this type 1 morphology, and then it will elicit this type 1 morphology, and then you diagnose Brugada. So what is type 1 Brugada morphology? This is the classical, Brugada-like ECG. Okay, so type 1. So you always want to see type 1 ECG to diagnose Brugada, either spontaneously or after provocative test. Okay, and then sometimes we usually place the leads high in the chest, like second, third, and fourth intercostal space, in order to try to see that pattern. Okay, type 1 pattern. Because otherwise, if you don't see type 1 pattern, you cannot diagnose Brugada. You have to see it somehow, either by specific ECG location, like placement, or after a provocative drug test. For example, in Europe, they give Agmaline, drug called Agmaline, which is a sodium channel blocker. Or in the US, they give procainamide, again, sodium channel blocker. And here in Kuwait, we only have IV flecainide, which is also sodium channel blocker. So with Brugada, they have sodium channel mutation, a loss of function of sodium. So when you give sodium channel blocker, that loss of function would be, enhanced or manifested, and then you might see that pattern in the right precordial leads. Okay, so Brugada, we don't see it very much in pediatrics because usually it manifests at roughly in adults. But when you see a patient because the dad had fainted or dad had arrested and so forth and was diagnosed Brugada, then you have to screen the kids, and this is how you should screen the kids. Okay, so this is why I met this family, because I'm seeing the daughter of this dad, okay, who had this ECG and had Brugada, clinical Brugada diagnosis. His genetic testings are not, he's not yet I just saw him recently. He's not yet is gene tested. Okay, so when you have Brugada syndrome, you want to recommend lifestyle modifications. Usually you avoid alcohol, for example. There are specific drugs that you should avoid, and you want to treat your fever promptly. Okay, and then you want to give ICD if the patient is a survivor of cardiac arrest or has VT or syncope. Okay, like symptomatic. Okay, some people will give quinidine, but I don't think we have quinidine in Kuwait. Quinidine is good for Brugada to prevent arrhythmias. Okay, anyway, so there's no great therapy for Brugada except avoid specific lifestyle changes or implant an ICD. So it's not really great when it comes to medicine, unlike the long QT syndrome. The genetic testing for Brugada is very low, meaning only 20-30% of patients with class 1 or type 1 ECG will have gene mutation that is recognized or identified. Okay, and the only gene that is proven to be associated with Brugada is SCN5A, which is a sodium channel gene. Okay, so again, remember there are drugs that you want to avoid for Brugada. Okay, guys, case 4. Again, this is 21 years old with palpitations. Okay, this is easy. What do you guys see? Oh, guys, this is easy. Abbas.
والاي سي تي سيجمنت اليفيت يا دكتور محمد، وفي البيك دي تي ويف كده في اكتر من
صح. But why is that?
مش هنتكلم عن الهايبر كاليميا مثلا. دي حاجه يعني.
Okay, why is there QRS negative here? Funny here. What's this?
PR is very small.
Very short, you mean? And then this means what? Suggests what? I thought this is easy. www, yes. Thank you. Okay. That should be easy. Okay.
ما احنا مش بندور على الدلتا ويفز اهو مش لاقيين.
Yeah, this is delta, but this is a very nice looking delta, don't you think? This is very nice looking delta. You have to train your eyes. These are all delta waves, okay? Okay, and then these are negative delta. Okay, that's why you get you are seeing the Q waves in LE3 and AVF. Okay, so WW, I mean, I'll talk, everyone knows WW. So it's an accessory pathway that connects the atria to the ventricle. Okay, and hence the PR would shorten because the time it takes for the accessory pathway to travel to conduct electrical activation from the A to the V is faster than your AV node. Okay, so again, this is your sinus node, this is your AV node. Let's say this is an accessory pathway. So the time it takes for the SA node to go down to the V across the accessory pathway is shorter than usually it takes for the sinus node to activate the AV interval at the AV node into the QRS, into the ventricle. Okay, so because the accessory pathway conducts electrical activation faster than your AV node, your PR shortens. Okay, and then because that accessory pathway inserts into a piece of myocardium that is outside your His Purkinje system, you will get initial delta QRS because of these muscles that are pre-excited, that are excited because of the accessory pathway activation. And so this piece of muscle would manifest as delta wave in the QRS, and then once the AV node is active, and then the QRS would normalize, and then you get a nice sharp normal QRS. Okay, so the QRS divided into two portions, delta and the QRS. Okay, and then rapid normalization of the QRS. Okay, guys, this is easy, صح? Because very often when you have when you have WW or accessory pathway, the QRS axis would change, while in a normal QRS axis is based on the His Purkinje system. صح? For the His Purkinje system, the LV is the main ventricle, So the muscle, both the LV and RV are activated at the same time, but the LV wins. So the QRS axis is towards the left side, and hence you are going to the left side, okay? And you are going to the left side and inferiorly towards the apex of the ventricles, okay? So you're going towards lead one, so you have QRS axis that's positive. You're going towards the inferior lead, so you should have 2, 3 AVF that are positive, okay? When you have an accessory pathway, that average ventricular depolarization is different now because you have a competing vector, okay? So then the QRS vector, or the axis of the QRS, might change depending on how that accessory pathway is affecting your average ventricular depolarization. Make sense, guys? Well, it's confusing.
تاني يا دكتور محمد معلش.
يعني normally the QRS axis is a function of يعني the QRS axis is this way, صح؟ لأن you're going toward the LV, صح? So you're going inferior and left. So QRS that are in lead one would be positive. QRS in AVF, for example, would be positive. Then you're going towards it. صح? Now we have an accessory pathway here. صح? So the QRS axis is not this, it's shifted towards this side. Then there are two ventricular activation. Okay? So the axis might change because of the accessory pathway. صح? Okay? For the QRS
تمام يا دكتور محمد.
okay? So the QRS axis might change because of WW. So this is one example, okay? So the QRS, it might, not always, it might change, okay? And then like you guys like you guys might have wondering, what you might wonder, why is the ECG looks funny? For example, the Q waves in lead 2 are funny, are wide, and are just abnormal looking. This is the negative delta wave and negative delta wave, okay? So so the Q waves, so you guys, the Q waves are also affected with WWY because the Q waves are, by the way, the Q wave is defined as any negative deflection that precedes the R wave, okay? So normally Q wave represents your septum being depolarized. صح, guys? Do you guys know this? We talked about this in the past. This is why I'm being fast. Okay, so the ventricular depolarization starts at the septum, okay? The septum is activated from the left ventricle to the right ventricle, normally, okay? So you're going from the left to the right, okay? From inferior to superior. This is normally how your septum is depolarized. So because you're going from inferior to superior, you're going away from the inferior leads. So then normally you should see Q waves in the inferior leads. صح? Make sense, guys? You see negative deflection before an R wave in the inferior leads because you're going away from the inferior leads when the septum is depolarized. Okay? And then you see Q waves in V6. This is all normal. Okay? طبعا now imagine you have an accessory pathway. The onset of the QRS is not septum anymore. It's the accessory pathway insertion, صح? So you might also lose your Q wave, your normal Q waves. Understood, guys? ولا لا؟ عباس شكلك انت سكت. عباس معاي؟
موجود يا دكتور محمد.
عباس كنت نشيط وبعدين ما صار فيك، نظرناك.
لا كنت بس باكل والله وانا
Okay.
كان بقوم.
Guys, so when you have WW, the QRS axis might change and your Q waves might change. Understood, guys? This is very important. This is basic EP stuff. Okay? زين. For example, this case, you have very big Q waves in lead 3, in lead AVF, in lead 2. So that's why you have abnormal looking Q waves, because there's an accessory pathway. Okay? You don't have Q wave in V6 because there's an accessory pathway. Okay? And Nabil, to answer your question, whenever you have QRS that's abnormal because of delta wave, for example, your repolarization would also be abnormal because the depolarization affects the repolarization. If you have abnormal depolarization, your repolarization would be abnormal. Okay, Nabil?
تمام.
So these S segment change just because WW. Okay? So with WW, you have obviously the patient is at risk of arrhythmia. The main arrhythmia is AVRT, atrioventricular reentry tachycardia, which is usually not, not life-threatening, but is very common with WW patients. So normally, this is what happens. Your AV node transmits electrical activation to both left and right bundles. Okay. When you have an accessory pathway, you have competing vectors, and that muscle that is pre-excited before the QRS, it creates a delta-looking wave. Okay. So when you have AVRT, what happens is for whatever reason, not for whatever, for a specific reason, the conduction goes down one AV node and goes up the accessory pathway. Goes down down the AV node, up the accessory pathway, instead of going down to both at the same time. Okay, guys. So when the electric activation goes down one, the other would allow the electric activation to go backwards, and then go downwards and then backwards and downwards, and this is SVT or AVRT. Understood, guys? Okay. Yes. Okay. These videos, by the way, from Dr. Joshua Cooper from he has a nice YouTube channel that he created those images. Okay. And then more concerning when you have WW patient, the patient is at risk of sudden death because of something called pre-excited atrial fibrillation. So patients with accessory pathway are at higher risk for AFib. Okay. For a reason that we don't need to explain. And then because they are at high risk for AFib, the accessory pathway, usually the AV node would block atrial fibrillation waves to depolarize the ventricles rapidly. But with the accessory pathway, the accessory pathway is not as smart, and then many of the AFib signals would go down the accessory pathway, and then the ventricle would contract very quickly, and then at some point might degenerate into ventricular fibrillation. Okay, guys. So this is why patients with WW might present with sudden death or might arrest because of that malignant ECG. And we have one patient with pre-excited AFib, and that was her ECG. The heart rate was like 350 beats per minute. Okay, so when you have irregular white complex tachycardia that is polymorphic, pre-excited AFib, especially in pediatrics, is one of your differentials. Okay. Rarely the patient might present with white complex tachycardia because the accessory pathway, the conduction is going down the accessory pathway, up the AV node. Down the accessory pathway, up the AV node. So you're going down this way. You're not using your His-Purkinje system, so the QRS is very wide. Okay. Or sometimes they have atrial flutter with WW as well. Okay. So this is what arrhythmias that are associated with WW. These are obviously rarer forms. The most common form is AVRT. Okay, guys. We did talk about this in the past, so that's why I'm quick here. Okay. So this patient underwent ablation, and with the ablation, the QRS axis normalizes, like you can see. You see, this is post-ablation, pre-ablation. The QRS axis normalizes, and then you obviously lose your delta wave. Okay, you don't see delta. You see this QRS complex here, versus here. Okay, guys, and your repolarization, Nabil, might remain like abnormal looking for a while. Okay, but this usually should normalize eventually. Okay, so anyways, you will get immediate ECG changes after ablation, but the ECG might not normalize fully. It might take a while to normalize fully. لأن في remodeling that is happening for a while. Okay, guys. Okay, Nabil.
تمام.
Okay.
دكتور محمد معلش سؤال قبل ما ننقل لحاجة تانية.
Yeah.
انت حضرتك بيفور ما تعمل اي بي ستادي بتبقى محدد ده غالبا اكسسوري ليفت اكسسوري باسوي او رايت اكسسوري باسوي، بتحددها ازاي يعني من دلتا ويف؟
That's a complex question, Abbas. We will discuss it some other day. There are algorithms, just to answer you briefly, there are algorithms that suggests the location of the accessory pathway. بس يعني only suggest like with sensitivity of 70-80%. Okay, so we always guess where the pathway is, but طبعا we cannot be 100% sure just based on the ECG. Okay, but we can tell. Okay, زين. For example, this patient had right posterior septal pathway, and we guessed it from before the from before the EP study. Okay, anyways, okay, so that's case 5, 38 years old, post tetralogy fellow repair. Okay, and he's by the way a doctor, a very smart pediatric cardiologist, an electrophysiologist, and interventionist. Like, he's a very smart doc. Okay, he's a friend of mine. Anyways, so what does this ECG show?
رايت باندل برانش بلوك محترم اهي.
Yes, thank you. Okay, so has right bundle branch block because usually the right bundle is in the inferior portion of the VSD, and when the surgeon closes the VSD, there is a high risk of bundle branch block, right bundle branch block. And then we did a study here in Kuwait, and then with all of our perimembranous VSD patients, we had incidence of right bundle branch block in around 55%. Okay, so it's very commonly seen after VSD closure. Okay, so case 6. This was simple case. Okay, case 6, 16 years old with palpitations. This is her ECG. What is striking on her ECG?
short PR interval.
Okay, بعد.
ST depression fleet 2 3.
ST depression. Okay, حلو. بعد.
inverted T waves.
Yeah, بعد.
5 و 6.
صح.
في LVS تقريبا.
اللي في اتش موجود كمان.
Yeah, big R waves in left leads with ST segment changes, T wave inversion, so like strain pattern. Okay, so this patient has probably LVH on ECG. Okay, no, not probably, like LVH on ECG, and then indeed the echo confirmed severe left ventricular hypertrophy. And then we did genetic testing, and she had something called Danon disease, which is very rare. It's a rare X-linked dominant metabolic disorder. Okay, so hence it's more aggressive in males. She was a female, so she has luckily a less aggressive form because it's an X-linked, so she has 2 X's. Okay, so such patients will have cardiomyopathy, mainly HCM, skeletal myopathy, maybe intellectual disability, some of them. She doesn't have intellectual disability, but especially men might have intellectual disability. They also have systemic manifestations, but again more pronounced in men. Okay, and anyways, cardiac wise, they have LVH with heart failure and arrhythmias. Okay, so what is Danon disease? It's a mutation that results in deficiency of LAMP2. Okay, and LAMP2 functions like it helps in getting rid of the aged cellular content within the cells, within the myocardium. Okay, so when you cannot get rid of the aged cellular contents, for example glycogen and other organelles, these accumulate in the myocyte, and then the myocyte get thickened. Okay, so the myocyte cannot just get rid of the dead organelles within the myocyte. Okay, so that's why the patient usually present with rapidly progressive left ventricular hypertrophy. Okay, it also affects the mitochondria, and there's mitochondrial dysfunction and so forth. Okay, so anyways, I will not talk about Danon disease so much. We had a presentation about Danon disease in the past. Okay, but just this presentation is mainly about ECGs. Okay, case 7, 40 years old with post-congenital heart disease repair. Okay, she's one of our patients who presented late, I think palpitations or just exertional symptoms, had an echo, and echo showed something. She had, what do you guys see on this ECG, by the way?
prolonged PR interval.
Yeah,
left
first
axis.
degree plus left axis, صح.
left
Okay.
axis.
Yes, so she has PR prolongation, left axis deviation. So when you see left axis deviation with congenital heart disease, what do you think of?
Fascicular block.
Yeah, but like what anatomy wise, what do you think of?
ACD.
AS شنو عفوا what did you say?
AVSD.
Yeah, AVSD. So she had you know, form of AVSD, and and you know and hence she had, you know, explaining her left axis deviation. So with congenital heart disease in adults, you know, when you have left axis deviation, obviously it is mainly associated with AVSD. And then in some patients, also tricuspid atresia patient will have left axis deviation. Okay. So these are the main congenital heart disease patients with left axis deviation. Okay. Okay. Case 8. Patient, this is a difficult question. Congenital heart disease patient. This is a patient that I just had seen recently. You know, he's not an adult. He's a pediatric patient, but has a complex heart disease. And then just so, you know, just to I'll just talk about this patient. You know, this patient has, you know, usually in V1, normally in V1, what is usually the QRS morphology in V1, guys? Like, is it usually this, right? صح? You should see an initial S wave, okay? Sorry, R wave, okay? So why should you see initial R wave in V1 normally? Anyone?
نرفلكت كده الرايت فنتركل الرايت فنتركل والليفت فنتركل يا دكتور محمد حسب الديبولاريزيشن بتاعه.
Yeah, so like we said, septum is depolarized first, صح? The septum
بالظبط.
is depolarized from the left to the right side, okay? V1 is a right-sided lead, صح? So your onset of the QRS, the vector of the QRS onset is towards V1, صح? You're going,
بالظبط يا دكتور.
yeah. So you should see R wave that represents your septum being depolarized from the left side to the right side, okay? طبعا this patient doesn't have that, okay? So that's a hint, okay? Anyways, so this patient had CCTGA or L transpose great arteries unrepaired, okay? So usually, you know, you might see subtle ECG changes. So again, usually your septal activation starts from left to right, but in this case is right to left. So you will have reversal of normal of the onset of the QRS. So you will lose your R wave in V1, and you will not have septal Q waves in V6. Okay. So V1, instead of an R wave, you'll get Q wave and dominant R. Okay. So your septum is depolarized as such now, not like normal. Okay. Okay. So this is the V1 and V6. You don't see Q waves in V6 and you don't see R wave in V1. So when you see such an ECG and you know the patient has congenital heart disease of some sort, you should suspect LTGA. Okay. Okay. Case 8, 16 years old who had an SVT, and we did ablation on her. So this is her ECG. What is striking on her ECG? يعني relatively difficult, but not that difficult. I'll help you. Look at lead 1. What do you see in lead 1?
هو البي اكسس مبدئيا دكتور محمد هنا دي انفيرتد بي ويفز موجودة ولا؟
Yeah. So there's negative P wave, negative QRS, negative T wave. صح?
مم.
What explains that finding?
Extracardia.
ديكيوكارديا.
Yeah. طبعا مرات يكون sisters just misplaced the leads. That's one differential, but dextrocardia is another differential. طبعا why is the patient has dextrocardia? Because also her left forces are very weak. Okay, so this is her X-ray. Okay, so she had indeed dextrocardia. Okay, طبعا she has also side inverted, like her stomach is on the right side. Okay, liver on the left side. Okay, so classical findings are P waves that are negative in lead 1 and AVL. QRS there is right axis deviation. AVR is positive, and V1 to V6, there's reverse R wave progression. Okay, so when you see such an ECG, you should suspect dextrocardia. Okay, Okay, last case, case 9, adult, Fontan patient, a little bit tachycardic, okay, palpitations, okay. This is a ECG, okay. What do you why do you think he's tachycardic?
flutter.
Yes, thank you. So he has, those adult Fontans are usually bradycardic. Fontans usually they have sinus node disease, usually. Okay, so they are usually on the slower side. When you get to see an adult Fontan whose heart rate at rest 90, 95, 100, 101, 105, and so forth, like above 90, you really, really, really should look at the ECG very carefully and make sure you're not missing flutter. Okay, so when you look at this patient, his heart rate, what's the heart rate? Like roughly 110 or something, right? 100 maybe. But you wonder whether there's a P, 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 P. You have to wonder that this is 2 to 1, not just sinus tachycardia. Okay. So any adult patient who is Fontan, who is tachycardic, you really, really want to make sure that you're not missing flutter. Okay. So this is his baseline ECG. طبعا, how do one thing that you should always do, look at the old ECGs, compare them. Okay. طبعا, you guys almost never do that. Always compare the old ECGs. Okay. So this is the old ECG. Okay. And if you look very carefully, so this is the current ECG in lead 2. So this is lead 2, old lead 2, and this is now lead 2. You see this bump, it was not present before, right? صح, guys? Make sense?
Yes.
Yeah. So this is, so indeed he was in 2 to 1 atrial, intra-atrial re-entry tachycardia or atrial tachycardia. Okay. So, okay. So I think we are done here. So again, this presentation is meant to be given to adult, cardiologists that, like they want to know, they want to get, let me stop recording, by the way.